Raleigh, you can start.
Well, thanks, Dr. Bajaj. So I entitled my talk today, Revisiting Blood Pressure Control, Arguments for and Against the Higher Treatment Thresholds in JNC-8. And we are going to have some questions in here, so please have your clickers ready. So the objectives for today's session are that at the end of this, you should be able to manage hypertension using evidence-based guidelines. You should describe the limitations of evidence-based guidelines, and you should explain the role of expert opinion in developing evidence-based guidelines. And I have no conflicts of interest to disclose relative to this topic. So what we're going to do is we're going to talk a little bit about an overview of the JNC-8 organization. We're going to talk about how it differed from JNC-7 in its organization. We'll review the recommendations from the JNC-8 panelists, and then we'll look at some of the arguments against some of the recommendations in JNC-8. Now this next slide is just to remind us, why do we care? And this just shows some of the complications of long-standing hypertension. So there's an EKG that shows left ventricular hypertrophy with an LV strain pattern. Long-standing blood pressure does stress the heart. The X-ray shows a dilated heart, so dilated cardiomyopathy can result from LVH being there for a long time and persisting against uncontrolled hypertension, or from ischemic cardiomyopathies. The brain cross-section shows an intracerebral hemorrhage, and so hypertension can cause strokes either through bleeds or thromboembolic processes. And then the coronary angiogram shows a tight coronary stenosis, and hypertension can cause not only coronary disease but other vascular disease as well. And I don't have a photo on here demonstrating end-stage renal disease, but another one of the complications of hypertension. So let's start with the question. You have a 64-year-old woman who presents with a blood pressure of 148/88. Which of these approaches would you use? Treat her with hydrochlorothiazide, monitor her blood pressure, treat her with metoprolol, treat her with lisinopril, or treat her with amlodipine. So go ahead and register those responses. They're rolling in. Well, I think there are probably more of you than 25, but we'll see what you said. So the majority said they would monitor blood pressure, and as we'll see, that is consistent with the guidelines that came from the panelists who were appointed to JNC-8. The next group said they would treat with hydrochlorothiazide. Some people would say that's a reasonable thing to do, and that hydrochlorothiazide is a good drug to choose for that. So this is an opinion question. Are you familiar with the JNC-8 recommendations? Just yes or no. Okay, so two-thirds say yes, a third say no. You will be familiar with them at the end of this talk. Have you actually read the JNC-8 report published in JAMA? Yes or no? So the majority of you are familiar with the guidelines, but the majority of you have not actually read the report that was published in JAMA. So you'll have meaningful familiarity with it at the end of the talk today. And then lastly, my opinion about the JNC-8 recommendations is agree with all of them, agree with some of them, disagree with all of them, don't know enough to have an opinion. So looks like people are pretty honest here. Most say just don't know. The next largest group say agree with some. It looks like one soul agrees with all of them. So this was the article that was published in JAMA. It was published online in December of 2013 and then published in print in January of 2014. And it's important to notice the title. It's called 2014 Evidence-Based Guidelines for the Management of High Blood Pressure in Adults. Report from the panel members appointed to the 8th Joint National Committee, parentheses JNC-8. It doesn't say that it's the report of the JNC-8, and you'll see why that's relevant and important as we move along. And if you want to read this, it's not a terribly long article. It's about 14, 15 pages. A lot of it's tables. So JNC-8 was originally organized by the National Heart, Lung, and Blood Institute in 2008. Now, the NHLBI is one of the National Institutes of Health. And so it was set up in 2008 to work on this project to publish new guidelines. The previous guidelines, JNC-7, were several years old at that point. But then, in June of 2013, the National Heart, Lung, and Blood Institute director announced that they were getting out of the issuing guidelines business. And I have, despite looking for the backstory on that, not really found the backstory on why they chose to discontinue issuing guidelines. In August 2013, they announced that the American Heart Association and the American College of Cardiology had agreed to produce guidelines on hypertension, cholesterol, and obesity. And they did, in November 2013, issue the cholesterol and obesity guidelines, but not the hypertension guidelines. So the NHLBI decision left the members of JNC-8 with sort of no sponsoring agency and what to do. And they had some discussion, do we take it through the process as if everything was continuing, or do we just go ahead and publish it at this point? And they made the decision to independently publish it in JAMA without seeking the approval of all the various agencies, taking the approach of let's put it out there and see what people think. They can decide on their own. So the way this process had originally worked, over 400 people were considered as panelists for JNC-8. They came from a variety of disciplines, things like primary care, hypertension, cardiology, nephrology, pharmacy, pharmacology, clinical trials, and several other disciplines. They ended up with a panel of about 48 people. So they went through this process, which we'll talk about a little bit more, and then at the end, in January of 2013, before they said we're getting out of guideline business, NHLBI submitted the report to 20 expert reviewers and 20 federal agencies. They ended up getting responses from 16 of the individual reviewers and 5 of the agencies. But this was never formally endorsed by the NIH, the NHLBI, the American College of Cardiology, and the American Heart Association. So they made a decision going into this. They were going to do an evidence-based review, and they decided we're going to have just certain kinds of studies that we're going to look at here. They decided they should be in adults, people over age 18 who had hypertension. Not people with pre-hypertension, not people without hypertension, but adults with hypertension. And they said small studies of short duration we're going to exclude. So if studies had less than 100 people and were less than a year in duration, they excluded those. And they said they've got to have at least one of these things that they're looking at in terms of outcomes. Total mortality, cardiovascular-related mortality, chronic kidney disease related to mortality, or MI, heart failure, hospitalization for heart failure or stroke, coronary revascularization or any other revascularization, end-stage renal disease, doubling of creatinine, or halving of GFR. And then notably, they had to be randomized controlled trials. So if it wasn't a randomized controlled trial, it didn't get included for consideration. So here's another question for you. Limiting the data review to only randomized controlled trials is a good approach. Agree, disagree, no opinion. So most 2/3 of people agree, a quarter disagree, and a few people have no opinion. And so when you make that decision, there are some limits that that imposes. One is you're only going to be able to look at things that randomized clinical trials have looked at. Randomized clinical trials are big projects. It takes a lot of work and a lot of resources to do them. So randomized clinical trials don't look yet at all questions that one could conceivably look at. And so when you make that decision, one of the things you're limiting yourself to is what the trials look at. So there are arguments for and against that. So these next two slides summarize some of the key differences between JNC-7 and JNC-8. So with the methodology for JNC-7, it was a non-systematic literature review where they looked at a wide range of studies. They didn't limit themselves just to randomized clinical trials. And the recommendations were based on expert consensus. Whereas JNC-8 prospectively defined critical questions, and they defined review criteria that they were going to use to look at studies. They restricted themselves to randomized clinical trials, and recommendations by the panel had a standard protocol that they used to say this is how we're going to make the recommendations. With respect to treatment goals, JNC-7 had separate treatment goals defined for uncomplicated hypertension and for various subsets who had various comorbid conditions. Whereas JNC-8 said we're going to have similar treatment goals for all populations except when the evidence review supports a different goal for a particular subpopulation. With respect to drug therapy, JNC-7 recommended 5 classes. They specified particular medication types that should be used for people that had other compelling indications. So, for example, if you had heart failure, they would say you ought to get diuretic and or ACE inhibitor and or ARB. Whereas JNC-8 said we're only going to recommend 4 classes based on the evidence that we've looked at. And we'll make specific recommendations based on your race, based on whether or not you have chronic kidney disease, and whether or not you're diabetic. The scope of topics was different. JNC-7 addressed a broad range of topics. Initial evaluation of people with hypertension, management of secondary hypertension, management of refractory hypertension, dealing with patient noncompliance, etc. Whereas JNC-8 addressed a limited number of questions which we'll look at subsequently, the ones that they deemed the most appropriate to look at. And then finally, the review process was different. JNC-7 was reviewed by the National High Blood Pressure Education Program Coordinating Committee. And that's a coalition that has 39 major professional organizations, public and voluntary organizations, and several federal agencies. And it sort of had the imprimatur or official endorsement of the National High Blood Pressure Education Program. Whereas JNC-8 was reviewed by experts, including those affiliated with professional and public organizations and federal agencies, but it did not have federal endorsement. And so that's why some people would say, you know, this is not JNC-8. This is a group of people that served on that committee who've made recommendations. So here are the questions that they prospectively said we're going to look at. The first one was, does initiating antihypertensive pharmacologic therapy at specific blood pressure thresholds improve health outcomes? That is, what numbers do we use to decide to treat? The second was, does treatment with antihypertensive pharmacologic agency to specified blood pressure goal lead to improved health outcomes? That is, if we're going to treat, how low do we treat? And then the third was, do various antihypertensive drugs or drug classes differ in comparative benefits and outcome and harms on specific health outcomes? So those were the 3 questions that they chose to look at, not the broad range of things like were looked at in JNC-7. So there are 9 recommendations they made, and we'll kind of march through those. And this is the first one, and this is the one that has evoked the most controversy. For patients 60 years or older, initiate antihypertensive pharmacologic therapy to lower the blood pressure at a systolic pressure of 150. So they said 150 is the recommended threshold for people over age 60. That differed from JNC-7, where that number was 140. And or a diastolic blood pressure of 90. So if either the systolic's above 150 or the diastolic's above 90 in people above age 60, the recommendation is they should be treated, and the treatment goal should be lowering the blood pressure to less than 150 systolic and less than 90 diastolic. They gave that a strong recommendation, a grade A recommendation, based on the strength of the studies they used to make this recommendation. There's ample data that demonstrates if you treat below those levels, you benefit patients. Now, a corollary recommendation they made was if you do treat and you get to lower numbers and the patient's doing okay, you don't need to back off on treatment just to let them rise back up towards 150. So if you treat and you get somebody down to 135 with your initial treatment and they're doing fine without adverse effects at that point, that's okay. Just leave them there. And that was an opinion just based on the members of the panel. There wasn't specific data that they used to say that, but just this is something that makes sense. So there was moderate to high quality evidence from randomized clinical trials that in the general population over age 60, treating high blood pressure to a goal of lower than 150/90 reduces strokes, heart failures, and coronary heart disease. They also determined that setting a systolic blood pressure of lower than 140 in this group provides no additional benefit compared with a higher blood pressure of 150. They noted there was lower quality evidence to support this statement. Now, this is different than saying there is no evidence that lowering it to that level is beneficial. But remember, they limited themselves to just certain types of studies, randomized clinical trials that met specific criteria. So here are some of the studies that they used to reach this conclusion. The hypertension in the very elderly trial, the systolic hypertension in the elderly trial, the Japanese trial to assess optimal systolic blood pressure in elderly hypertensives, valsartan in elderly isolated systolic hypertension trial, and the CardioAssist trial. So there were several studies that supported this conclusion. Their second recommendation was, in the general population younger than age 60, initiate pharmacologic treatment to lower blood pressure at a diastolic blood pressure of 90 or higher and treat to a goal diastolic of less than 90. So for ages 30 to 59, there's strong evidence to support that recommendation, grade A recommendation. For ages 18 to 29, not so much data from randomized clinical trials, because it's not hard to imagine that most people in hypertension trials aren't between the ages of 18 and 29. And so for this younger age range, just the opinion of the panelists was that let's just use the same number. Let's go ahead and treat those younger folks down to the same age. So here's another question for you. Do you think that raising the systolic blood pressure goal from 140 to 150 in people over age 60 is appropriate? Yes or no? Or no opinion? Okay, so most of you agree that's a reasonable goal. All right, we'll look at some of the other recommendations and end up talking about what other people think. So regarding their second recommendation, treating people less than 60 to a diastolic of less than 90, they found that initiation of antihypertensive therapy at a diastolic of 90 or higher and lowering it to 90 reduces cerebrovascular events, heart failure, and overall mortality. They also found there's no benefit in treating patients to a goal of either 80 or lower or 85 or lower compared to 90 or lower based on the randomized clinical trials they used to develop their recommendations, which is different than saying there's no evidence at all that this may be a benefit. So in adults younger than 30, there really aren't any good or fair randomized clinical trials that assess the benefit of treating elevated diastolic blood pressure on health outcomes. Just not that many folks in that age range to comprise a good randomized trial to date. And so they said in the absence of such evidence, we are just going to recommend that we have the same diastolic treatment thresholds that we do for people aged 30 to 59. It'll be easier for people to remember these guidelines if we don't have too many different thresholds in there. So we'll just say 90 like the people that are ages 30 to 59. And studies they looked at included the Hypertension Detection and Follow-Up Program study, the Stroke Cooperative Study Group, the Medical Research Council Trial of Hypertension, the Australian National Blood Pressure Trial, the VA Cooperative Study on Hypertension, and the Hypertension Optimal Therapy Trial. Their third recommendation, and notice they separated 2 and 3, whereas for older age groups their systolic and diastolic were in the same recommendation. In the general population younger than 60, initiate pharmacologic treatment to lower blood pressure at a systolic blood pressure of 140 or higher and treat to a goal of less than 140. And this is based on expert opinion as opposed to the strength of the studies that were available. And what they said is there's insufficient evidence from good to fair clinical trials to support a specific systolic blood pressure threshold for people younger than age 60. In the absence of any information like this, they felt like it was appropriate to stick with 140 as the number because that was the number that was out there in JNC-8, and they said in the absence of any data, there's no compelling reason to change the current recommendation. That when you look at diastolic blood pressure trials, many people that were treated to diastolic goals did in fact get to blood pressures of less than 140, and that the similarity of that goal to goals in groups with chronic kidney disease and diabetes would just make it easier to implement these guidelines. So this was an expert opinion recommendation for systolic blood pressure in people younger than age 60. Their fourth recommendation was in the population age 18 and over with chronic kidney disease, initiate pharmacologic treatment to lower systolic blood pressure at 140 or higher and diastolic of 90 or higher, and aim to get it to less than 140 systolic and less than 190 diastolic. That was an expert opinion recommendation. So in people younger than age 70 with chronic kidney disease, they said the evidence was insufficient to determine if there's a benefit in mortality, cardiovascular, or cerebrovascular health outcomes with antihypertensive drug therapy to a lower blood pressure goal than 140 over 80, for example, 130 over 80, compared with the goal of 140 over 90. There's moderate quality evidence demonstrating no benefit in slowing the progression of kidney disease from treating with an antihypertensive drug to a lower treatment goal, for example, 130 over 80, compared to the goal of 140 over 90. And the trials that they looked at, included in this part of the analysis, include the African American Study of Kidney Disease, Modification of Diet in Renal Disease Study Group, and RAIN-2, which looked at renal protection in non-diabetic patients with chronic renal disease. The fifth recommendation was, in the population age 18 or older with diabetes, initiate pharmacologic therapy to lower blood pressure to systolic of 140, a diastolic of 90, and treat to less than 140 over 90. Again, this was a recommendation based on expert opinion as opposed to the strength of the trial data. They noted that there was some moderate quality evidence that in adults with diabetes and hypertension, treatment to a goal of lower than 150 improves cardiovascular and cerebrovascular health outcomes and lowers mortality. They noted also that there were no randomized clinical trials addressing whether treatment to a systolic goal of less than 130 compared to a higher goal, 140 compared to a higher goal of, say, 150 improves health outcomes in patients with adults with diabetes and hypertension. And so they made this recommendation to say, let's aim for 140 in people with diabetes based on congruence with other recommendations. That if we have fewer numbers that we're trying to help people remember, it'll facilitate guideline implementation. And studies that were looked at for this part of the recommendation included the systolic hypertension in the elderly trial, the systolic hypertension in Europe trial, and the United Kingdom prospective diabetes study. So if you have diabetes, the recommendations for over age 60 don't apply. So those are over age 60 if you don't have diabetes and if you don't have chronic kidney disease. So if you're over age 60 and have diabetes, the lower recommendation applies. So recommendation 6 looked at race. In part looked at race for recommendation of drug therapy. So they said in the general non-black population, including those with diabetes, initial antihypertensive treatment should be a thiazide diuretic, a calcium channel blocker, an ACE inhibitor, or an ARB. And they gave that a grade B recommendation. They noted that only randomized clinical trials that compared one class of antihypertensive to another were included. So if you had a randomized clinical trial and it just compared active treatment to placebo, they didn't really include that here since they're trying to decide relative efficacy of treatment. And so for each of the 4 drug classes they included, thiazides, calcium channel blockers, ACE, and ARBs, they yielded comparable effect on overall mortality, on cardiovascular outcomes, on cerebrovascular outcomes, and kidney outcomes. The one exception was heart failure, where heart failure outcomes were not the same. Heart failure, thiazide-type diuretics were more effective than a calcium channel blocker or an ACE inhibitor in preventing heart failure. and an ACE inhibitor was more effective than a calcium channel blocker in preventing heart failure. Beta blockers were not recommended for initial treatment because in one study that compared valsartan to atenolol, beta blockers resulted in a higher rate of the primary composite endpoint of cardiovascular death, MI, or stroke compared to the use of the ARB. And that was largely due to increased stroke. So beta blockers had been in the first-line category of drugs recommended in JNC-7, and they fell out in these JNC-8 recommendations. Alpha blockers were not recommended as first-line treatment because in one study, initial treatment with an alpha blocker resulted in worse cerebrovascular, heart failure, or combined cardiovascular outcomes than initial therapy with a diuretic. That was the ALLHAT study. They also noted that on these drugs, we didn't have any good randomized clinical trials to guide us, and that's why they're not included in the recommendations. So there are no randomized trials that compared one of the 4 recommended classes to dual alpha and beta blockers, things like carvedilol or labetalol, vasodilating beta blockers, nebivolol, central alpha-2 agonists, clonidine, direct vasodilators like hydralazine, aldosterone receptor antagonists like spironolactone, adrenal neuronal depleting agents like reserpine, and loop diuretics like furosemide. So they basically said there's just no data to let us make recommendations related to these, and we're making recommendations based on the ones for which there is data. And so there were several trials, and these are just some examples of the ones they looked at that are listed here. The LIFE study is where they compared losartan with atenolol, and that was the basis for not including beta blockers. And ALLHAT was a study where alpha blockers fell out as not being as effective. Recommendation 7 was, in the general black population, including those with diabetes, initial treatment should include a thiazide-type diuretic or a calcium channel blocker. So for the general black population, that was a moderate grade recommendation, so the data was pretty good, but not as strong as grade A data. And for black patients with diabetes, it was a weaker recommendation, a grade C recommendation, because the data was not as strong. Recommendation 7, the evidence related to this is based on really just one study, the ALLHAT trial, which is a very large prospective study that was rated as good quality. In that study, the thiazide-type diuretic was shown to be more effective in improving cerebrovascular heart failure and combined cardiovascular outcomes compared to an ACE inhibitor in the black population of patients, which included large numbers of people that had diabetes and were not diabetic as well. Recommendation 8. In patients with chronic kidney disease and hypertension, initial or add-on therapy should include an ACE inhibitor or an ARB to improve kidney outcomes. And this applies to all patients with chronic kidney disease regardless of race or diabetes status, and they gave this a moderate grade B recommendation. This is based primarily on kidney outcomes because there's less evidence that favors an ACE or an ARB for cardiovascular outcomes in patients with chronic kidney disease. So this is specifically directed at people with chronic kidney disease and hypertension and addresses the potential benefit of drugs on renal outcomes. Use in African American patients with chronic kidney disease is based on expert opinion as opposed to randomized clinical trials. And the choice is less clear for African American patients with chronic kidney disease but without proteinuria. So if you have proteinuria, the strength of the evidence is stronger that it's reasonable to use ACE or ARBs in African American patients. But if you have chronic kidney disease lacking proteinuria, the data is not as strong. And studies that were included here include the African American study of kidney disease and hypertension, the renal study, and the collaborative study group. So the last of the recommendations, recommendation 9, the main objective is to attain and maintain good blood pressure. If the goal blood pressure is not achieved within 1 month of treatment, increase the dose of the initial drug or add a second drug, and continue to assess blood pressure and adjust the treatment at monthly intervals until the blood pressure goal is reached. If you can't get there with 2 drugs, add a third drug. So based on looking at clinical trials and kind of the frequency of follow-up in clinical trials, their recommendation was a month is a reasonable amount of time to give somebody to have responded to therapy. And if they haven't, then you should consider changing therapy. That was based on expert opinion. So let's talk about some of the limitations of this set of guidelines. First limitation is they just looked at a few things. They said, what are the thresholds for initiating pharmacologic therapy? What are the goals of pharmacologic therapy? What do you want to treat down to? And what are the comparative benefits and harms on specific outcomes of certain drugs? So these are the only questions they ask in the JNC-8 analysis of the literature. So that's one of the limitations it's important to keep in mind. So other issues that might come up in hypertension are really beyond the scope of these guidelines. And there are a lot of patients that we treat that would look different than some of these clean populations. So it's not uncommon that I treat patients over age 60 who are smokers, who've had a stroke, who have diabetes, hyperlipidemia, and coronary disease. And so most of these studies don't include that sort of patient in their patient populations. They also didn't include observational studies or systematic reviews. It was only randomized clinical trials, and they didn't do their own meta-analysis of the data. So that's another limitation. The randomized controlled trials that included participants with normal blood pressure were not included because this was looking only at treatment of patients with established diagnoses of hypertension. So if you looked at, excuse me, patients that in JNC-7 would have been categorized as pre-hypertension, they weren't really included in this. And in cases in which high-quality evidence was not available or evidence was weak or absent, the panel relied on fair quality evidence and panel members' knowledge of the published literature outside the randomized clinical trials that were reviewed and personal experience to make recommendations. So where you see all these recommendations that are grade E, expert opinion, there they've deviated beyond what the randomized trials say, and they've tried to acknowledge that. Another factor to take into account is some of these studies are really old. The hypertension detection and follow-up study was started over 40 years ago. I was in high school then. And things were different then. The drugs we had available to treat people were different. How effectively we got the blood pressures down were different. We weren't treating lipids like we do now back then. So the treatment effect may have been overestimated in some of these studies because some of them are really old. Now, there are some different organizations that have come out and said, we have real concerns about this. So we're going to talk about some of them. The first one is the Association of Black Cardiologists. And they had several critiques to make. First of all, they noted that the National Heart, Lung, and Blood Institute tasked the American College of Cardiology and the American Heart Association with the long-awaited JNC-8 document for vetting and shepherding through the final stages of the guideline process. And, well, it didn't really go through that shepherding and final vetting. It got published. Some of the JNC-8 panelists were not in agreement with this process, well, the majority, or the reviews of the document, and they chose to publish it separately. They published it in JAMA. And remember, the title was by the members appointed to the JNC-8 of the article as opposed to JNC-8 itself. But they also note that everybody calls it JNC-8. I've been calling it JNC-8 this whole time we've been talking. And when you look at the literature, everybody calls it JNC-8, even though it wasn't officially sanctioned in its final form as such. And the Association of Black Cardiologists also points out that neither the National Heart, Lung, and Blood Institute nor any other federal agency sanctioned this guideline. They went on to say that it was their opinion that the 2004 recommendations were flawed in design, that they were constrained by the use of only highly selected randomized controlled trials, which drastically understates the literature supporting a more aggressive approach to controlling hypertension. And some of the studies they mentioned were some aspects of the CardioAssist studies, a meta-analysis of randomized clinical trials in pre-hypertension, but remember they weren't looking at pre-hypertension here, and the blood pressure treatment trial is collaboration. So they said there's a lot of other data that if you'd included that could have led to different recommendations. And so some of this depends on, where do you put your stake in the ground at the beginning? Do you say it's randomized clinical trials and that's what we're going to base it on, or we're going to look broader? They went on to point out that raising the systolic blood pressure to 150 millimeters of mercury in persons who are greater than 60 years of age, especially African Americans, who are prone to end organ damage from hypertension, may have substantial negative impact on gains that have been made in the last several decades in the treatment of cardiovascular disease. They pointed out that the black-white life expectancy gap remains wide for both men and women and is driven largely by the adverse effects of poorly controlled hypertension and associated cardiovascular disease. And they expressed real concern that loosening these goals might have the unintended effect of further widening that racial gap in terms of outcomes, especially for older people who may have worse problems in these areas. Now, the Working Group on Women's Cardiovascular Health also had concerns about this. They note that cardiovascular disease in women has been understudied, underrecognized, undertreated, so that there have been suboptimal outcomes in the population of women. As most people that are older than age 60 in the U.S. are women, there will have the potential to be a differential effect on women compared to men by raising the blood pressure threshold. And they went on to say that the 2014 recommendations offer no recognition that the hypertensive population is primarily female, that older women generally have poorly controlled blood pressure, and about 40% of those with poorly controlled blood pressure are African American women who have the greatest risk for stroke, heart failure, and chronic kidney disease. So these were the concerns of the Working Group on Women's Cardiovascular Health and the Association of Black Cardiologists. Now, this is a very interesting paper in that this is the minority viewpoint. These are people that were members of the panel that was appointed to JNC-8, and all of them except one, Fine, were actually members, authors of the article that was published in JAMA, the main set of recommendations. But these 5 people had strong enough feelings about this one recommendation, and we're really talking about the 150 number as the issue, that they published a separate article that was published in Annals of Internal Medicine in April of 2014. And their main points were that increasing the target blood pressure will reduce the intensity of blood pressure lowering in a large population who is at risk for cardiovascular disease. That the higher goals will apply to groups who are at the highest cardiovascular risk, African Americans, people with multiple cardiovascular risk factors, and people that already have clinical cardiovascular disease. And they felt that evidence supporting raising the goal was insufficient. So there are really kind of 2 ways to look at this. Is there evidence to support raising the goals, or is there evidence to support the lower goals? And the majority of people on the panel felt like they should look at is there evidence to support the lower goal, and if not, go with the higher one. These minority members felt like, is there evidence to raise it, suggesting we ought to raise it, and in the absence of that, leave it alone. And they were concerned that the higher systolic blood pressure goal for people over age 60 would reverse decades of a long decline in cardiovascular disease, especially stroke mortality. And it's true, if you look at the data, we've had a long period of gradually declining cardiovascular disease and stroke mortality. And so they're worried that this will be reversed. Finally, they said, we, the panel minority, these 5 members, believe that the evidence was insufficient to increase the systolic blood pressure control goal because of concern that increasing the goal may cause harm by increasing the risk for cardiovascular disease and undoing the remarkable progress in reducing cardiovascular disease in Americans who are older than age 60. Now, there are other criticisms that we could speak to, but with respect to time, I wanted to focus on some that sort of paint the picture overall. So now I have a question for you. Now that you've seen what the recommendations are and some of these criticisms, what do you think about this new blood pressure goal of 150? Do you think it's a good idea, a bad idea, or do you still just have no opinion? Some people are asleep at the wheel, don't even have no opinion. All right, so almost 60% think they're a good idea, about a quarter think they're a bad idea, and a few have no opinion. So I think it's important when you're looking at guidelines to say, guidelines are guidelines. That's what they're there for. They're there to give you guidance. They're not there to absolutely make decisions for you. And you have to look at the patient that you're considering. And so if you have the patient who's over age 60, who already has clinical cardiovascular disease, you probably want to control that blood pressure more tightly than you would somebody who doesn't. If you have a healthy 75-year-old who runs marathons and works out every day and has 0% body fat and their LDL is 60, you can probably let their blood pressure ride higher than somebody else. If you have somebody with multiple cardiovascular risk factors, you'd probably want to consider setting a lower goal for your blood pressure. So it is important to think about guidelines as what they're intended to be, guidelines, not rigid rules for this is how you should do it. The evidence-based approach taken by JNC-8 was reasonable, but when you take that approach, it does mean that you end up omitting some of the evidence that may support treatment, but we also have multiple examples over the years of when evidence supporting doing something ended up proving to be wrong once you had a randomized clinical trial to support it. So it was not that many years ago when I was giving estrogen to postmenopausal women because it seemed like a good idea to do. But then when the data came out from randomized controlled trials, it proved to be a bad idea to do. I used to give a lot of vitamin E to people because it seemed like it was a good idea to do, not likely to be harmful. There's been some evidence that there may be harm from giving supplemental vitamin E. And there are lots of practices we've used over the years. So it was not an unreasonable decision to limit this to randomized clinical trials, but it means you're likely to end up at a different point than if you said, we'll look at all the data that's out there. Any comments or questions? So that wasn't primarily what they looked at. They didn't look at event rate of adverse events. They looked at evidence for efficacy in preventing those endpoints they looked at, like cardiovascular mortality, stroke, end-stage renal disease, et cetera. So they didn't look just at adverse events related to those. Now, one of the things in practice that you see is there are some patients it's hard to get below goals without having unacceptable adverse events. There are a number of patients I've had over the years where you get their pressure lower than 140, they have stiff arteries, they start getting lightheaded and dizzy. But that wasn't really what they looked at here. Dr. Dracy, do you have any comments? This is kind of an area near and dear to you. Well, so hopefully you have a better understanding of what some of the issues are behind guideline development and these guidelines. If you want to read any more, the first reference here is the main report of JNC-8 that was published in JAMA. The second one from Journal of American College of Cardiology talks about the arguments from the Association of Black Cardiologists and the women's group compared to JNC-7. And the last reference is the minority view from JNC-8, the members that were on the panel that authored the report saying, here's why we disagree with that. So, thank you very much.